Well, welcome everybody. I'm so glad that you taken some time out of your day to be with us. I'm Jason Eckert. I'm here today to talk a little bit about the expand vision rehabilitation through a multidisciplinary approach. I want to just give a moment to one of our sponsors, one of our sponsors from the conference and year-round sponsors at VSA, which is Amgen. Niaz Zulfagari is a representative from Amgen, and she's just going to take a minute to talk about Amgen. So, Niaz, let me send it to you.
Thank you, Jason. Hello, everybody. Hope you're all having a great day. My name is Niaz Zulfagari. I'm part of the thyroid eye disease patient advocacy team at Amgen. For those of you who are unfamiliar, thyroid eye disease, also referred to as TED, TED, not to be confused with the conferences. It's a rare disease where the muscle and the fatty tissue behind the eyes become really inflamed, and it results in symptoms such as redness, irritation, eye bulging, proptosis, light sensitivity, etc., but especially changes to vision. In fact, if it's a delayed diagnosis, delayed treatment, it can result in vision impairment and often, sometimes, or not often, but sometimes blindness. So up to 50% of those that are diagnosed with Graves may also develop the thyroid eye disease. So we are stressing the importance of early screening for those with thyroid disease. And also just to note too that while there are physical changes that a person might experience who is undergoing TED, there are a lot of psychological and mental health impacts as well, which can impact someone's day to day. So if you're ever interested in learning more about thyroid eye disease, and there are different patient resources that we have, such as the ones that are through VSA, and exploring other ways to support our community, you can visit us at thyroideyes.com.
Excellent,
Thank
and
you.
and thank you so much, and thank you for your continued sponsorship. And I will highlight for a moment that there is the Thyroid Eye Disease Foundation that works on the patient advocacy committee with me and Amgen, and we are always able to make connections to that organization if anybody here has clients or patients that they're working with that are struggling with thyroid eye disease. So please just be sure to always reach out to me and be able to do that. And at Amgen, again, we thank you for your support. So much of this couldn't be done without contributions from an organization like yours. So thank you
Thank you.
again.
Appreciate it.
All right, on that note, I'm going to jump in and get started. Many of you know me again, Jason Eckert, the Chief Operating Officer for VisionServe Alliance, and I'll be assisted today by Helen Chapman, so I can stay focused on what I need to present, and Helen can help move the slides along and I don't get myself too distracted, which can happen. Which can happen with me. So this is I'm going to actually start talking just off of our first slide because it's the Expand Vision rehabilitation through a multidisciplinary approach. And this is going to be very similar to what I presented at the conference, but for those who might have seen that, they'll know that the title of the presentation has changed. We called it, Vision Rehabilitation Services, a healthcare debate at the conference. And one of the great things that came from the conference was as we talked about a multidisciplinary approach and bringing other professionals into the vision rehabilitation field, and what that would look like, the group that I was with, this was one of our breakout groups, kind of came to the consensus that there wasn't really a spirited debate, that we were talking about a different systems model. And that was a systems model that a lot of people at the conference were really able to get behind and support. So I'll start with that in mind and the change of topic, although the presentation will be just about the same. So I always like to start things like this with a quote, something that seems meaningful to me. And this one is a strong one that this book I read in graduate school. So we're talking many, many years ago that's really held with me. And that is, the only real security in life lies in relishing in life's insecurity. And that's from N. Scott Peck in The Road Less Traveled, a classic psychological psychiatric book that was written 40 years ago, probably now. And the reason why I like this is we're frequently in times that are not secure. We're in one of those times now. You know, the times they are changing, right? As we all know. And what we can gain comfort in is we can worry about that, have fears about that, or we can simply acknowledge that that's a part of life, and then we can sort of relish in it and enjoy it. So we're in a change. Things are changing in the vision rehabilitation system. Things are changing in the way healthcare and educational services are provided in our country. And as a result of that, we have this opportunity to sort of acknowledge that there's some insecurity and choose to relish in it. I'm going to want to build on this concept a little bit with the next two slides, just to play around with how we perceive the world, because I want us to be in a space where we sort of open our minds and open our thought processes as we talk about some of the real traditions that we've had in the vision rehab community. So for those who can't see or have difficulty seeing the slides, there is a classic psychological optical illusion on the slide, and it's a square image, and it's a figure ground play. And the figure ground play is that in this one picture, you can see two things. You can see within the shaded portion, two profiles that face each other, and you can, like two profiles of faces, and you can look at this and say, oh, this is a picture of two silhouettes facing each other. Or you can look at this picture and say, this is a picture of a vase that I might very well put flowers in, right? So it's the face-vase illusion. And whatever your first impulse is, that's an impulse. That's the way you saw this picture. If you can see both, that's terrific. If you still only see one, that's your perception. That's how you're seeing this situation in this moment. And others are seeing the situation in this moment different. And the key here is that you're both right. Neither one of you is wrong in the way that you see this. And if you have the opportunity to see both, then that's a terrific extra vantage point. The next slide is just a little bit more complicated to show that this concept might be hard to grasp. Some things are easier to see both sides and some things are harder. So this is called old lady, young lady. Some people call it daughter-in-law, mother-in-law. And it's an image that if you look at it in a certain way, you might see the profile of a young lady, the back of her head, her hair, her ear, her necklace. If you look at it in another way, you might see, oops, you went too quick, but that's okay. Yeah, you might see an older woman. You might see her nose and her eye and her mouth. So this is, again, just the concept that perception is sort of what we see versus what we choose to see. We do have some power to keep studying things and choose to see different. And both perceptions are right, depending on where we are in the situation. Okay, let's jump in. Next slide. So when we jump in, I'm going to talk a little bit about today how this all started and what this process of creating a multidisciplinary team looked like and why VSA is involved in it. Several years ago, as many of you know, VSA took the pulse of what the community wished, and the community wished for us to help provide services, more understanding and discussion of services for older people living with vision loss. As a result of that, they created the AVLNC committee, a committee that still exists today. And now it's actually more independent than it was in years in the past. We just administer it. Carly Rhodes and Chris Rogers are our co-persons for that, co-chairs for that committee. And I really encourage people to participate in it if they wish. AVLNC asked VisionServe Alliance to do different amounts of research to make a determination if vision rehabilitation services can be supported by Medicare. And in order to create that process, we developed the Medicare Exploration Project after we did the Big Data Project, which I'll talk about and many of you are familiar with. And in the Medicare Exploration Project, we had two phases. So I'm going to briefly talk about what happened in phase one and how that is now affecting where we are in phase two. And this presentation is sort of part of our phase two process. So the objective here was basically to see how we can increase Medicare and other healthcare providers' coverage for vision rehabilitation services. And in order to do this, we did a few things. We examined what non-traditional payment methods are that are available through the Medicare system. We evaluated the services that are provided by what I'll call our traditional providers now, the CLVTs, the CVRTs, and the COMs. And I'll use those terms interchangeably. I recognize that there are some folks out there that might be trained a little bit differently that do this work or do not have their certifications. But I will say that VSA really does support people getting certified in these areas through ACVREP. We've had a wonderful partnership with them, and we support the certification services that they have. We wanted to analyze current models for physical, occupational, and speech therapy coverage within Medicare Part B. I'll explain that a little bit more later. And we also wanted to take a look at what evidence-based research we already had. What research is out there that shows that vision rehabilitation makes folks who have it live more independently, stay at home longer, reduce accidents and slip and fall, all of those things that we know. Where is the research related to that? So this is what we analyzed in phase one to make a determination of what we would do in the Medicare Exploration Project. There were some thoughts in the beginning of this project that it might be interesting to represent a demonstration project to CMS to have our traditional folks get paid in a traditional Medicare system. That was one of the thought processes there. But after having a lot of consultation, meeting with CMS and taking a look at what that process would involve, we made a determination to go another route. And we presented on this when we closed phase one and opened phase two about 18 months ago in a presentation like this one. So what we determined was that there are three things that need to be done. One was there are mechanisms to use traditional Medicare to have vision rehabilitation services paid for, and that's through occupational therapy. Two, second suggestion that came from phase one was that there is alternative funding within the Medicare system. And if we access that alternative funding, Medicare, Medicaid, and what's the overarching government agency, CMS, if we access that, we would be able to have our current traditional providers, CLVTs, CVRTs, COMs, we'd be able to have those providers covered by Medicare in a different way. And that we needed research, more research to continue to make the argument that vision rehabilitation services are effective for those who receive them. Okay, so let's just talk a little bit about these three things. So we say in the first part that we're going to talk about what services occupational therapists can provide and what it would be like to have occupational therapy in the vision rehabilitation system. Now, spoiler alert, some of you on the call here today, some of the agencies that you represent, there already are a significant amount of occupational therapists that are in the vision rehabilitation system. A good amount of our agencies are already using occupational therapists to provide some vision rehabilitation training. So one of the things that started to come out of that was that there was a desire for occupational therapists to have more education, more experience in vision rehabilitation and providing clinical vision rehabilitation services. Now, occupational therapy, like many medical or healthcare professions, has a lot of specialties. We're all familiar with the specialties that our doctors have, but that trickles itself down into allied health professions like occupational therapy as well. So VisionServe Alliance developed a process, a training program, to provide occupational therapists with more clinical training for vision rehabilitation services. So that became one part of the training in this phase two. A second part of the training in the phase two became that occupational therapy as a billable service for Medicare is very different than the way that VisionServe Alliance, not VisionServe Alliance, that the way that the agencies provide vision rehabilitation services. There are constraints on medical billing and constraints on the profession of occupational therapy that are different than the way most of us are used to billing and provided services in the traditional vision rehab professions. So we created a simultaneous track of training for administrators where the administrators can start to gain an education on what it's like to do medical billing for this particular profession, how those things should be written up, supported, how occupational therapists can be moved into a Medicare billing system. What does that look like? So we created a dual training to give occupational therapists more experience in vision rehabilitation and to give administrators more experience in their ability to actually use occupational therapists and create another funding stream through occupational therapy at their agencies. We did those two things simultaneously. That was supported by the Lavelle Fund for the Blind, and we are about halfway through that grant application, and I think it's going quite well. So there's also this non-traditional form of vision rehabilitation, and in non-traditional vision rehabilitation services, we're talking about non-traditional Medicare payments. So there are a lot of alternative Medicare incentive programs that provide payment for folks to live healthier lives, to go to the emergency room less, to have a successful transition out of a hospital setting, to participate in their community health organizations or community care hubs. There are a lot of non-traditional ways that Medicare provides contracts to organizations. Also in non-traditional, I include things that come through a Medicare Advantage program and certain Medicaid waivers that are administered on a state level. We lump all these things together in non-traditional funding for vision rehabilitation because if you access Medicare funding or Medicaid funding or CMS funding through these avenues, then the credentialing criteria is a little bit less strict. And when it's a little bit less strict, the credentials that we already have, the excellent credentials that we already have through ACVREP, are way above some of the standards that we would need to get reimbursed, right? So there's another way of providing that. So in the slide that we just had previously, we talked about the vision rehabilitation process and educating the occupational therapists and administrators. I neglected to mention that we used a consultant, Visions of Independence, a gentleman by the name of Elliot Feldman, who's probably on this call, who has been an excellent co-facilitator and educator of me and VisionServe Alliance and our agencies on how to actually do that type of work. And in this setting, we hired another consultant, Sharon Jackson Williams of Jackson Consulting. And Sharon does this part specifically for a living: how to educate on these particular programs, how to gain access to these particular programs that are non-traditional Medicare funding and non-traditional billing sources. So many agencies participated in that part of the training as well. And again, it's my opinion that that went very well. This is a little bit challenging. Both of these are a little bit challenging in the way to set up the systems in order to access funding from this way. But that is our goal here. Our goal here is to create additional funding streams for the services that we know provide consumers with more independent living and all of those positive things. And for all of that to happen within our agencies, for our agencies to be able to provide this amount of services that we think is best. So finally, the third aspect of this is TTI Health Economics. TTI Health Economics is a company that we are working with, and they are doing a meta-analysis of we took a look at the research. If you remember in part one, I said that we pulled a whole bunch of research together and we did some analysis of it to make a determination. Do we have enough research to actually do a meta-analysis and make a statement that says vision rehabilitation services are effective in this, right? We figure out what the this is. What's the case statement there? So we discovered in phase one that we think we had enough research. In phase two, we hired the professional who will do a meta-analysis. They've reviewed about 200 plus studies, pulled out 36 studies that can be collated together. Again, this gets challenging. What's the case statement? Do we all like the case statement? How are we measuring our entrance and exit? But we've had a way. We'll use the oh my God, it's jumping out of my head. The Vision Rehabilitation questionnaire that's normed by the National Eye Institute, the 2548. There's some thoughts about that within the community, but that's a normed tool that we can use. And we've found in our preliminary stages some good trends that suggest that we would be able to put a white paper out, we hope, and identify that vision rehabilitation therapy will be helpful. Vision rehabilitation services will be helpful. We hope then to be able to use that to accentuate the amount of payments that services can receive. We can use that as our evidence. Let's take an opportunity, right? I've mapped out, that this could be an insecure time. I've mapped out that we could view this in many different ways, and both ways can be right? We can have opposing opinions, and both opinions can be right. I've gone through what we have learned from AVLNC's challenge to VisionServe Alliance, what we've learned from the first phase and now halfway through the second phase of the Medicare Exploration Project. And it's time to take a reflection. It's time to take a reflection and say, is what we've learned opportunity or a threat, right? And again, if we can hold that perspective that we can see both sides of this, that helps us choose a path forward. And we have, in fact, chosen a path forward. So there we go. So the choice there is that we're going to choose to view this as an opportunity. That we have a really unique opportunity now to enhance the services under the umbrella. I'll talk more about that in a minute, of vision rehabilitation services. And we have the opportunity to provide more services to the clients or patients, participants, consumers, whatever word your organization uses, that come to our doors, that we really believe that this is an opportunity. I just want to talk about the big data project that VisionServe Alliance did, because this is part of the argument for the opportunity. We can argue numbers all day, and I get very resistant to writing numbers in certain places because they can be challenged by other sources, and no numbers are perfect. But I'll take some shots here based on our big data project. Based on our big data project, our statistics show that there are about 8 million people in the United States, age 18 to 64, that are blind or low vision. And there are about 4 million 65 and older that are blind and low vision. Again, you can get very different numbers by looking at very different research with different case statements. So I can't argue the point. These are the numbers I'm going on. And that older adults with vision loss, based on our research, are 2 to 3 times more likely to experience comorbidities compared to their sighted peers. Again, that's a very broad, rough statement, but it shows out in our big data research that when you start to talk about comorbidities, especially in seniors, the senior population with vision loss compared to the senior population without vision loss is sort of 2 or 3 times more likely to have comorbidity X. That does basically pan out in our research, and it's important to think about as we think about incorporating occupational therapy services onto a vision rehabilitation team. All right, so I get a little nervous here on these slides, and I'll punt the ball till a little later in the presentation for a moment. But what we do know is that we have less CLVTs, CVRTs, and COMs out in the world, mostly in the United States I'm talking about, than we do occupational therapists and certified occupational therapy assistants. We just know that. Again, those numbers are a little hard to find, but I'll give some in a little bit, but that's a statement that we're going to start with. And graduate schools and graduates for last year. I had the graduate number for 2024, everybody, and somehow it got pulled out of my notes. I don't know how that happened. And it's a little hard to calculate because it's not easy to find. So I don't have it for today. But again, we know it's much less. I did manage to re-pull some of the data that I had for graduate programs. And if I'm being, in my opinion, pretty liberal on the graduate training programs for all aspects of vision rehabilitation that aren't medical, so CLVT, CVRT, COMS, CADIS, TVI, things like that, we have about 40 schools that have graduate training for that. If we look at the amount of schools that we have for occupational therapists in graduate programs, that number is easy to find. That's 272. So again, we just know we have a larger pool of folks who can help our population. Why is that important? Why is it important that we have a larger pool? And it's important because, again, with numbers, very tricky, but we know that vision rehabilitation needs, versus the amount of services that people get is really vast, right? The percentage of people needing services versus those receiving them is very dramatic. Now, again, there's a lot of research here, and a lot of research asks different things. So I get a little cautious as I go forward. One of the things that I hear frequently is that, about 95% of people who need vision rehabilitation services don't get them. Okay, I think that number is a little overly ambitious, although the number is still very high. That number, from my research, and you all could have different research, sort of shows up when we talk about RSA and older blind funding and the amount of older blind funding. But when we talk about the totality of the rehabilitation system, it's my belief that that number improves, but it doesn't improve dramatically. And it certainly doesn't improve dramatically enough to miss the point here, that we need more professionals in the field. I'll talk more about that as well. Also, when we talk about our funding, for OIB funding, for older blind funding, that supports our folks who have vision impairment who are seniors. We're really talking about funding it. There's allocations that go up every year, but sometimes they're not put in the budget. So again, I'm rounding a little bit, but we're talking about, 36, $37 million and numbers that haven't gone up in a long time. So if I'm talking about 4 million seniors that need service, and we're talking about, 36 or $37 million, we can do fast math in our head and know that what are we talking about? $10 a senior. Um, and not having an infrastructure that would be able to support that if every senior got service. Again, you can challenge these numbers, which is why I'm saying them and not writing them. But just gives us a ballpark that the argument is that we need more folks. Other services, the VA provides some services for our veterans who have vision loss, and that doesn't have to be combat-related vision loss. So some people get services through that system. NFB does certify folks, and there's an NFB system that exists where training can occur, or people go to the NFB facilities and have some training there. And some of those folks get certified and counted in a different way. And as we know, there are a good amount of non-professionals that are doing this kind of work, or professionals in other fields, as we're identifying. So again, just some things that play around with the number of people who are getting vision rehab services. And so the medical profession for vision rehabilitation services. So when I think of vision rehabilitation services, I think really broadly. A visit to an ophthalmologist counts, a visit to an optometrist counts. And so they make the list, obviously, they're medical professionals. And here I've listed 3 other medical professionals. We're focusing on occupational therapists because they're the ones that seem to be doing the most work on this now, and they're the ones that are most interested. There are some programs where physical therapists are doing some of this work, but they're still pretty few and far between. And then when we talk about speech therapists, speech therapists are identified in the CMS law as being able to provide this service, but I have not seen speech therapists sort of identify themselves in this way. If it's out there, come back to me and educate me. But for the most part, the numbers are the largest in the occupational therapist spaces. So I want to identify that we're not the only folks in this space where there's a shortage. Very clearly, there is a tremendous shortage in ophthalmologists that specialize in low vision. There is a low vision division of the American Academy of Ophthalmology, and it is pretty low in membership. And for optometrists as well, the amount of optometrists that specialize in low vision compared to the amount of optometrists that are licensed across the country is really low. The optometry has a national certification. You can become a diplomat in low vision services, and certain states certify low vision specialists. So again, numbers get hard to count. You have to know every state that certifies versus the ones that don't. Some people have certification in their state as an optometrist, but they are not a diplomat. Some people are diplomats and they're not certified in their state. So these things always get complicated when it's time to count the numbers. The point here is that there is a shortage across the board in vision services, healthcare or otherwise, in our country. So I promised some numbers, so here they are. If we look at the amount of occupational therapists that we have in the country right now, we're talking about almost 145,000. If we look at the amount of occupational therapy assistants, we're talking about 52,000. And if we look about the ACVREP certificates, people who have certifications, we're talking about 4,100. So thanks to the folks at ACVREP. That's a couple of months ago. I know these numbers always change, so there could be a little bit of difference, but these were the numbers that we were able to pull at the time. So obviously we see that. Now again, 4121 is not the only amount of people. These get more complicated. I have non-certified professionals like we talked about. We have people who are certified in different ways. We might have some of these occupational therapists that are already doing the work. So some of these people could be administration and not doing clinical work. The numbers vary with how we're providing the services, but we can see here that we need to do something in order to increase the amount of certified professionals, licensed professionals who are providing face-to-face services in vision rehabilitation. Okay, so here is the vision rehabilitation team in its fullness, right? If we could imagine an agency that had everything, and you can add a couple more to these if you want to. But we're talking about an ophthalmologist, a optometrist. We're talking about an occupational therapist. We're talking about a certified vision rehabilitation therapist. That's a catchment for CLVT, CVRT, COMS, CADIS, right? Just catch all those together. Orientation and mobility specialists, social workers, counselors, case managers, care coordinators, and other health, social, and educational services, right? We'd like this to be the full wraparound comprehensive services that every person who is experiencing vision loss has access to. It would certainly be our belief that if everybody had access to all of these folks in all these different disciplines with all these different job titles and tasks, that they would be able to get the best comprehensive wraparound care while they're experiencing vision loss related to their vision. So the hope is that's what we can push for. That's what we can incorporate. So I wanted to talk about two other systems where this seems to happen, not exactly in both systems, but it seems to happen. So first we take the Veterans Administration. The Veterans Administration is really a nice model for what it's like to have comprehensive wraparound vision rehabilitation services. Because the Veterans Administration has identified, first of all, they accepted and reimbursed for payment for our ACVREP certificates. So that's really valuable. But those folks work side by side with the other professions that we identified. In that community, in that setting, ophthalmologists work side by side with optometrists. Occupational therapists work side by side with COMS and VRTs and O&Ms, and right, those services work together, and they augment each other in very positive ways. The same thing is true in our school systems. It would be very common, in districts that are run well with good special education and vision rehabilitation, that TVIs, work well side by side with occupational therapists, and that a school counselor or a school social worker or school psychologist work well with some of these other disciplines. So there are models out there where disciplines have identified a team approach where they can all work together. And I like to highlight those two models there. So let's talk a little bit about sort of the funding resources so we can tie all this together. So many of our organizations are funded in a variety of ways when we're talking about non-medical funding. Different states do this differently, so there's going to be 50 different ways, and then there are regions and states, and it could break down even further. But we have, for general, what I would call the state office for the blind. Some states have this as its own unit. Some state offices have this as part of other units. They act autonomously. They don't. They're mixed in with disabilities. They're not. They're mixed in with the Department of Labor. They're not. So you have to know, but for the most part, we do have sort of state offices that provide blind services. That money comes on point two from the Rehabilitation Services Administration. That money for folks who have a vocational goal, either over 55 or under 55, but have a vocational goal, that comes out of sort of the VR pocket, the vocational rehabilitation pocket. If not, for those folks who are over 55 or 65 without a vocational goal, that becomes our older blind funding, right? And that funding comes available. I put on pre-ETS funding because those who really know this system well know that some vocational money was kind of sucked out of the system and forced to be spent on some of our younger folks who are living with blindness and low vision. We have other government funding. Some states provide matches. Some states provide line item dollars for blindness services. Some states provide line item dollars to specific agencies in their state for blindness services. Again, this is a mix of government and politics that comes into play when organizations get services. Some counties, larger cities and municipalities also offer additional services for folks with vision loss, especially if we're talking about the older population. There's money related to that. So again, there are these budget line items. They're all there through all these municipalities. The agencies themselves, of course, have donations, have endowments, have specific programs, have grants that they seek to get to provide programming. So that's sort of another funding stream that comes into the agencies. And then there are some offices that people have been very successful with, where they have sort of placed blindness as part of and vision loss as part of the other service. So children and family services, mental health services, disability services, senior services, and transportation services are places where there are carve-outs for folks who have that issue and their vision impairment. Again, as you start to think about this, this is all very relatable to what we learned in the big data project. Okay, so we have medical services. Again, as I talked about, we have traditional medical services. I go to the doctor, I have an appointment, and someone gets paid for providing that service. And we have non-traditional services. I go to a place that helps me stay healthy. That place has a contract with Medicare to get money when they prove that I have stayed healthy. I haven't gone to the emergency room. I haven't slipped and fallen. I've shown up every day. I've eaten a meal there. I've shown that I am healthy. That's kept me out of the doctor's office. It's kept my medical expenses down. And that non-traditional service says, hey, pay me because I kept John or Sam or Sally healthy. Next slide, please. Okay, so traditional medical service, again, Medicare, private agency, and Medicaid, or private insurance and Medicaid. Non-traditional, and there's a little crossover, Medicare Advantage programs, independent living programs, hospital discharge programs, group medical practices, CMS health incentive programs, and Medicaid. In this instance, it might be a local Medicaid waiver or something like that. So again, we're talking about accessing things from saying, here's a traditional doctor, I've got an optometrist, I've got an occupational therapist, I want to bill for that. And here is a program, Medicare Advantage. You pay for glasses. If you also pay for vision rehabilitation, that person can have that as part of their sort of their glasses program that you normally don't pay for. If it's independent living, it might be participating in a senior center. Medicare Advantage, it might be exercise program or something like that that we can bill for. Think of senior sneakers and the YMCA. These are actually Medicare funded programs. Okay. But when we're talking about our traditional, we're talking about our occupational therapy billing. So our occupational therapy billing, right? This service has to come from a medical doctor. A medical doctor has to give us a referral for a patient that they're working with who has vision loss. And that patient is going to then see our occupational therapist at our organization. And we're going to provide service for them and bill for that. An ophthalmologist can always refer, a general practitioner can always refer, anybody with an MD at the end of their name can always refer. An optometrist can usually refer, but optometry is a little different, and different states have different rules about it. So if you want a system where you have a low vision optometrist and you want them to refer for occupational therapy, check your state's rules and regulations to make sure that that referral can come and you can bill off that particular referral. In most states, you can. Okay, so one of the things that I want us to think of is also treatment plans that are beyond the scope of vision rehabilitation. Again, I've been alluding to this. Turn your mind back to the big data project, right? If we have 2 or 3 times more likely to have a comorbidity, if someone has vision impairment than they're a senior, let's say, then we know that that comorbidity provides something that an occupational therapist can treat and we can bill for. So again, when we're thinking of broader services, or make it even broader, think of that entire rehabilitation team that I thought about. If a comorbidity happens to be a diagnosis of depression, is that something that you can hire a social worker or a psychologist or a licensed professional counselor to bill Medicare for, and then move that money through your agency? So as we think about the broader services, I want to encourage us to think about comprehensive wraparound vision rehabilitation services and how adding an occupational therapist to it might help us to be able to provide some services that we don't provide now. Our goal is to keep people in the amount of services that they need, to have enough interaction with face-to-face with professionals that know what they're doing, that are licensed or certified, right? That we deem competent, that can provide more hours of service for the patients that we're serving, the clients that we're serving, the consumers that we're serving. So again, you can think about that. You can expand the scope of the type of work that an agency provides. Okay. So healthcare and the expanded rehabilitation team, this is just what I was identifying before, that we can think of services beyond what we think about as traditional vision rehabilitation services. The healthcare team can be broader than that in these instances. Where to start? So a target group of where to start is with older Americans. Now, say, why, Jason? Why is that a target group? Why start there? For a couple of reasons. One is that we know that the older Americans have more comorbidities that we can address. Two is that we know that the funding is much more limited in the older blind funding programs than it is in the VR program. So we have less state dollars for our 65-year-old person who's new to vision loss without a vocational goal. We have less dollars to access than in that system than we do for a 35-year-old new to vision loss with, in our system, right? Because VR dollars are stronger than the OIB dollars. So again, it sort of makes sense. They have the second morbidity that we can address in expanding our practice very easily, and there's less money surrounding them in the system, right? Also, when we talk about older Americans who are being new to vision loss, they're much more comfortable with the vision rehabilitation, with the medical system than the traditional vision rehabilitation system, right? The research does pan out that they get a little antsy. They don't consider themselves disabled, or they may not consider themselves blind yet. Those words even might make them uncomfortable. So it is a profession that's easy for them to understand. If I'm 70 and I have diabetes, and I have a friend that has diabetes, and that friend has a toe or two amputated and has occupational therapy, that makes sense. And then if I have the same condition, but I have diabetic retinopathy, and I have occupational therapy to help me with that, that makes sense. And around my social circle, you had diabetes and went to an occupational therapist, and I had diabetes and went to an occupational therapist, right? It matches. It's a little bit more even for this consumer to understand and comprehend. Yes, I want them to have vision rehabilitation services. Yes, I want them to understand that what being a vision impaired individual means. Living with blindness and low vision, what that means. But we have to ease these folks into it. They have been living a sighted life, identifying themselves as fully sighted and non-disabled for 60, 70, 80 years. Changing that narrative in their mind takes a lot of time and patience. And again, that's why we want to enhance the services for them. So here are demographics, which we've talked about already. Over 65, vocational goal, right? That the money is less there, and we have that impact of 2 to 3 times more likely, so we can address some of these complex health needs. In giving these type of talks previously, I used to spend a lot of time trying to get a group to have consensus on what services an occupational therapist might do that are unique to occupational therapy, what services a vision rehab professional might do that are unique to vision rehab, and then what services cross over in the middle. And inevitably, every time I brought up this chart and tried to finish this Venn diagram, the room got into too many arguments to move forward. So I've changed my strategy here, and I leave this chart to you. I leave it to you to say, take a look at what your vision rehabilitation therapists that are traditionally trained do. Take a look at what occupational therapists that are traditionally trained to do. Know that those occupational therapists can get enhanced training in vision rehab, and then make a determination as to what crosses over, what goes in that enhanced services. And instead of seeing that as a space where people are doing other people's work or interfering in other people's scope of practice, recognize that that is a space where you have flexibility. You have flexibility to assign 2 professions to do that type of work, freeing up that profession's time to do the work that is uniquely theirs. That is really the value of this. If I have 2 professions who can do one thing, and I've identified that I only have 1 profession that can do something else, then I can divide up their service and make access of their time the best way that I can. That's the most advantageous for my organization. So it's a way to think about that. This is how we enhance services. Also, not all the professions that we discussed can be reimbursed by the multiple systems that you may have. So that again may cause you to use this Venn diagram to make some very good choices, where you would say on this side, because I can be reimbursed from insurance, I'm going to have the occupational therapist do this. On this side, because I can be reimbursed by my state contract, and my state contract requires that I have a CLVT or CVRT to do this work, then I'm going to do it this way, right? So you can make administrative decisions, you can make clinical decisions. The Venn diagram can really help you determine what needs to be isolated because of skill set and because of reimbursement, and where you can maximize that by having two professions performing the same tasks. I like to say that this is not unique to us, which is why I have all these professions here. Optometrists and ophthalmologists in our community argue about this, right? Optometrists and occupational therapists argue about this. Occupational therapists and certified vision rehab professionals argue about this. If I go into my training profession, psychiatrists and psychologists argue about this. Psychologists and social workers argue about this. This scope of practice is alive and kicking in the medical profession. And if we are going to participate in the medical profession, well, guess what? We join just like the rest of the disciplines in that profession that argue with each other. We are no different. We are not special in that practice. So I encourage you to think about this as a way to do business. The last slide is that here is the principle of creating this comprehensive vision rehabilitation team, including this new discipline that we're talking about as occupational therapy. Our goal is, in principle, to provide face-to-face services and training with qualified professionals. We want to increase the amount of time that a 70-year-old senior gets to spend with professionals. More time with optometrists, more time with ophthalmologists, more time with VRT, more time with CADIS if that's what they want, more time with O&M, and more time with occupational therapists. We want to get more hours, and we want those hours to be funded appropriately. We want to ensure that there is steady, well-funded payment streams for all the vision rehabilitation services that we can provide, so our agencies can be strong and healthy, so every time somebody knocks on our door, we have a professional that can serve them, and we can invite more and more of these people who are not knocking on our doors to do so. Whew. So that's it, everyone. We have some time for question and answers. Happy to, if there are questions in the chat, I'm just happy to open it up in any way.
We do have a couple questions, and I'll also allow folks to talk. So if anybody wants to ask a question verbally, they're welcome to do that. So Anicio, he asked a couple of questions. He said, just a comment, just to keep in mind that 4 million of the 65 plus for OIB funding is actually for 55 plus. So the per capita amount is actually even smaller than what you had suggested earlier.
That's absolutely correct. I was just assuming wrongly that those 55-year-old folks could still have a vocational goal, but he's absolutely correct.
And then his question was, how much VR funding is available for blind and low vision folks nationwide from RSA on average, if you know that?
I do not, but I will look it up and get it back. I don't know what the allocation was, but we should be able to find that. You can usually find that in the law. Sometimes it's difficult to tease out if it's mixed in with the general population or with labor, but we should be able to find that through RSA. Great question, though.
Okay, great. So everyone is allowed to unmute if they wish, or you can drop a question in the Q&A or the chat.
Hi, Jason. This is Erica Petak from Visibility.
Hi, Erica.
Yeah, I have a quick question. So we utilize OT services right now for a lot of our vision rehabilitation, as you know. And one of the things that we are struggling with is copays and deductibles. So a lot of our people who are used to getting vision rehabilitation services and not having a copay or a deductible are very unhappy about this, to the point where they say, well, we're just not coming for services then.
Yeah.
And one of the things we've learned is that you can't just get a grant and say, well, we're just going to cover your copay or your deductible with it. So we're trying to find creative ways to cover those things so that people will come and utilize the services they need. Do you have any recommendations around that, or anybody else on the call?
Yeah, I'll answer, but maybe there's a recommendation there. I just want to be very careful that you have to be very careful not to run afoul with your if we're talking Medicare, just for simplicity, with your local Medicare office, right? So Medicare is our national program that's divided into regions, and you're billing through your region. And your regions, we've determined this in our training, your regions can be different and give different instruction, right, from region to region. We've even had an example in our training where people were in the same region but had a different representative and got different advice. So there are scenarios where you can simply waive that, right? And I've heard that some orgs, some regions and folks will let you just simply say, okay, there's no copay, we won't collect it, right? Or you can try to collect it so you have evidence of that, but then, not try too hard.
Yeah.
Or you could, or you could sort of force the payment, but identify that there might be parts of service
Mhm.
that they eventually would be at no cost to them. Notice I don't like to use the word free, as many of you know.
Sure.
So that would be at no cost to them. So at this part of the service, because I'm getting billing this way, I have to charge you the copay. But when you're
Mhm.
done with this part, you move into this part, that it will be no cost to you. But I do want to encourage you to check with that local office because I don't want you to run afoul,
Okay.
on that, and then the office tell you that you've been out of compliance with Medicare rules.
Sure. Okay. Thank you.
But it's a real issue that comes up, Erica. So I'm glad you brought it up. When people combine these services, this issue comes up a lot in low vision when we have low vision doctors that are also billing Medicare at agencies. Great questions.
Jason, this is Charlene Gordon with
Hi,
Care to Care.
Charlene. All my friends are
Hi.
here. Hi, Charlene.
Hi. Could you talk a little bit about lifetime services? Like in Michigan, we have something that's called PACE, and they provide ongoing lifetime services. And if you've looked at anything in terms of, I know the VA says that they are a lifetime service for the veterans.
Yeah.
So have you looked at anything that relates to lifetime services and that would involve ongoing support financially?
Oh, great question, Charlene. I'm going to say no, right? I just am going to say that most of the services that we've identified here have some type of ending goal and don't put themselves out as sort of lifetime services the way, let's say, like the VA does. Now, obviously, if you're accessing Medicare for somebody and they're, whatever, they're retired and they have Medicare, then they will have Medicare, ongoing. That becomes but it's not identified that way. And even when we talk about the community care hubs or we talk about the community organizations that have contracts, those things I haven't seen, Charlene, is identified as a quote unquote lifetime service. So I'm going to answer no. My guess is, though, that probably locally within some of those jurisdictions, in some of these non-traditional Medicare services, again, where there's some org that has some contract with Medicare to keep somebody healthy, and then they're sort of circling back to our disciplines and saying, you're going to help me keep this vision impaired person healthy, therefore I'm paying you off of this contract. There's probably something in there in individual services where we would find this. But I can't speak to it. I just can't speak to it beyond that type of sort of speculation and my imagination.
Thank
But
you.
when I'm on the Michigan call, I'm going to ask you to tell me a little bit more about those lifetime services up in your neck of the woods.
Absolutely. Thank you.
You're welcome.
Hi, this is Lois from Savannah, Georgia.
Hi, Lois.
Hi, I want to ask about, you mentioned accessing Medicare programs such as Silver Sneakers and some of those. Is that just across the board? Do most states have perhaps a list of Medicare programs, affiliated programs?
Great question. So I'm going to respond to your phrase across the board, right? Just let me respond there first and say it's in my experience in doing all this work that nothing is across the board, right?
Okay.
Even when I'm in the federal regulations, the way the federal regulations are implemented through state organizations or through federal regional offices, it really changes dramatically from either state to state or kind of region to region. So I want to caution against that thought process. But I love the question. The question is, where are these programs available? So they're broadly available in one or two or three places. One would be in the way that your state in Georgia is executing Medicare Advantage programs, right? Most of these services exist in Medicare Advantage programs. They're services where people have stepped off Medicare Part B they've participated in the Advantage program, and the Advantage program gives them benefits. So that's the first place to look. The first place to look is where there are Medicare Advantage programs that provide these type of benefits, and then who is certified. That's the wrong word I want. Who has a contract to provide those services? Is it my local United Healthcare or my local Aetna, right? And are they providing those services? So these things tend to be pushed into community organizations. So if I have, let's take Silver Sneakers. If I have Medicare Advantage and that gives me Aetna, right? That's my private insurer now. Instead of Medicare Part B, I've got Aetna. And now I look in my Aetna brochure, it's going to say I have Silver Sneakers through the YMCA, right? So then the YMCA is who's getting paid from Aetna, who's getting paid from CMS in order to provide this program to keep the person healthy. How does that relate to vision loss? For us is a very ripe opportunity. Most Medicare Advantage programs get the business that they get because they provide vision and dental services. And most seniors, particularly who are having trouble with their vision, right, are going to access those programs. That's why they picked Medicare Advantage, because they want to be able to get new glasses. So that is the right place for us to go forward and to say, I provide vision rehabilitation services, you're providing glasses to seniors through Aetna Medicare Advantage. And when that goes bad, it's not a refraction error, it's macular degeneration, it's diabetic retinopathy, it's advanced glaucoma, I would like a contract with you so I can provide these vision rehabilitation services that will lower your patient's health cost and lower their access to multiple doctors through the Medicare Advantage program. Does that make sense? I know it's a little complicated.
No, it totally makes sense. I appreciate your answer. Thank you.
Okay, well, we stopped on time, which is a great accomplishment for me. I really want to thank everybody for being here. I'm really open to all of this. I would say, Helen, if you want to drop in the chat my email really fast. I just realized we didn't put that on a slide. I'm open to any discussion about this. The projects that I talked about with VisionServe Alliance are continuing, so we will have other trainings in this area. And any help that VisionServe Alliance can provide here, please reach out to me. I really wish to thank our partners in the Jackson Consultant and the TTI, Healthcare Economics and Visions of Independence. And we get a lot of support in pulling these things together from ACVREP and AER. I want to thank our partners there. Really, this has been a large effort, and we're really excited to talk about this and to move some of these ideas forward. And all discussion is good. So please reach out if you wish. And I thank you for spending this portion of your day with me.